Hello and namaste. Good afternoon or good evening, wherever you are. This is a webinar for the Mehelp India Foundation, looking at approaches to mental health in rural communities in India. We have an exciting interactive webinar planned for this afternoon in conversation with Dr. Tasneem Raja. Welcome, Dr. Raja, to our webinar for Mehelp India Foundation. I will introduce our guest panelist in a minute. Before I do that, let me say a bit about Mehelp India Foundation. Mehelp India was a research project funded by the UKRI in India, in southern India, in Kerala, looking at mental health literacy in urban and rural communities. We created such a space within the Indian context within a short span of 3 years of having fearless conversations, discussions, theater pieces, theater shows, film shows, and storytelling practices within urban and rural and tribal communities in Kerala, to such an effect that many of the people who actually told us that you need to continue this work for a longer period of time. So we have registered Mehelp as a charity. Mehelp India Foundation is a charity in India. And we're continuing with that work with these webinars and people who are actually currently working with us to promote mental health literacy through schools and through working with grassroots organizations in southern India at the moment. So this webinar is also live on Facebook, and so feel free to actually ask any questions through the question and answer box or to the chat box as well. So we would like it to be very truly interactive in such a way that we are actually able to answer some of your questions or your comments or your concerns in relation to the generic theme of mental health literacy. Because mental health literacy is not just the awareness of mental health alone or mental illness. People often talk about mental illness when we talk about mental health, but I think it's more than that. It is, however, it is about how we actually understand the various conditions. It is about how we understand the stigma and the concerns surrounding that. It is actually about how we find out the right kind of information about mental health and well-being, and also about mental distress. It is about how we seek help and the right kind of help-seeking processes, whatever it might be, based on your cultural, religious norms or other kind of practices that you may actually have. And it is also about the kind of professional help that you can be able to approach. And it is more about kind of the self-help approaches that you might be able to actually practice in your own life, also within the family context or social network context, etc. And it is also more about how you understand the kind of cultural, religious, cultural heritage context around mental health and well-being. So we believe that there is nothing called mental health literacy as a unified concept, as the Western psychiatry actually tells us. We think there is mental health literacies as a concept, whereby it's more holistic. We look at the traditional practices, we look at faith healers, we look at astrologers, we look at everything else that one might be actually doing, along with the kind of medical, psychological, psychiatric help that one might actually seek. So it is with that in mind that we want to actually look at mental health literacy in the broader context of the Indian urban and rural communities, and also within the professional context as well. Because one must be very careful not to actually over-medicalize our own emotions. There is a limit to medicine and how we look at other aspects of things, how we look at creative arts, how we look at sociological context of illnesses, and how we look at creative basis of arts, theater, and other ways of actually dealing with and learning about things is also very crucial in understanding about mental health and well-being. So feel free to be to ask us any questions in relation to our discussions. The process is that I would introduce Dr. Tasneem Raja, and then she was going to actually talk for about 10 minutes in relation to her thoughts on approaches to mental health literacy in the rural context, and then we will actually go into kind of a question and answer discussion mode. And within that process, you will also, the participants will also be able to actually ask any questions or express any other views through the chat box or through question and answers. So a very warm welcome to all of you who have actually joined the webinar. Thank you for taking the time to support us. So first and foremost, our guest, Dr. Tasneem Raja. She is a master's, she's got a master's in clinical psychology, and she has conducted advanced training in public health with special focus on mental health. She was awarded a PhD from the University of Warwick in 2021. Dr. Tasneem embarked on her professional journey as a psychologist, working with people affected by addiction and HIV and AIDS. Her professional path took her across the length and breadth of India, working on a diverse set of health issues with various vulnerable groups. She has over 25 years of experience in healthcare sector and has worked in a range of issues, including non-communicable diseases, infectious diseases, and maternal and child health in various parts of the country. Dr. Tasneem has a keen interest in the facilitation of people's participation in healthcare access. Up until recently, Dr. Raja was actually working as a mental health lead in the Tata Trust, and she has recently moved to the Indira Foundation as one of its leads in India and also from the global health perspective. So a very warm welcome to you, Tasneem, to our webinar this afternoon, and thank you for taking the time to join us. So over to you in relation to our key theme for our discussion today, approaches to mental health literacy in a rural context.
So many thanks, Dr. Raghavan, for the many conversations that have happened over the last 1.5 years with you, and the very engaging ideas, thoughts, and content that you're constantly putting out on mental health literacy and very usable snippets that regularly come out from you. Apart from that, thank you very much for inviting me today on today's webinar. And I look forward to having an engaging discussion with you and the participants. And we hope that there are a lot of questions and comments from the audience that have joined us today. So mental health is, of course, no longer an issue of the yonder. It is at our doorsteps. It is a part of our daily conversations today. If you close your eyes and think of it, you might think of that person who needs some help. You might think of an uncle who lives down the road who may be dealing with forgetfulness. You may have a friend or a colleague who at times struggles with loneliness. These are all part of the human spectrum of experiences. That said, what really is mental health? It is a state of well-being that allows us in which we can accomplish our full potential and be productive individuals looking after self and contributing to society. In a nutshell, that's what mental health is all about. And if you look at it, it's a continuum where we are all at some stage on that continuum, and at one end of it is the disorders. 1 in 5 adults will have a mental disorder at least once in their lifetime. And for countries like India, when you translate that number, just think about this for a moment. That's about 15 crore people out there who need help, and here's another fact for you. Less than 30% of that 15 crore ever get any form of care. And we're not talking professional care here. Less than 30% get any form of care. So like Dr. Raghavan nicely put together for me, the various facets of mental health literacy. Now, when we're talking in the context of rural communities, a lot of the work that I have done has been with rural communities in different forms, as a contributor to design, as a as a representative, helping put together programs, and as a person who's directly implemented programs on ground. So rural communities are inherently different. Yes, on the one hand, there is social capital, and that itself is being debated today, that there is a depletion in that social capital. Yeah, and the way, in fact, a lot of the mental health constructs and concepts are also in the zone of debate and controversy. However, what a rural community understands, and perceives is, or what any community understands and perceives, is determined by their context, by their culture. What is supposedly non-normative in a community may not be so in another. So going by Western constructs that define mental health or illness in a certain manner may not be the most helpful thing, is the first uh, understanding that I developed working as a professional with communities, that looking at it from a community's perspective, or looking at how a community understands or perceives something, is very important. And the negative or positive connotations that we may levy on something does not necessarily translate to how a community looks at it. The other important perspective as an implementation professional, as people who go into communities, one of the things you learn is that you may go in with the idea of a program. The best programs, however, are the ones that can iterate with the learning, the knowledge, the inherent wisdom of a community. That's when you get maximum success, and you kind of are able to adhere to the first principle of intervention, which is do no harm. The other thing that Dr. Raghavan touched upon is the coping mechanisms that a community has. How do you harness the coping mechanisms that are already present? And I'm going to now jump into talking about some of the things that I have seen or done over the years that have worked very well, and bringing in the aspect that Dr. Raghavan already spoke about. Accessing or working with communities. How do you work with them? The rural reality of rural communities is very different. The occupational engagement that they have is very different. The one thing that works is follow the time schedule of a community, not the time schedule set by a program or by a civil society body. And you will see that you get most effectiveness when people have a little time to talk to you, when there is leisure, when people are in a mind frame where they can engage. So evenings, for example, late evenings, when people come back from work and are sitting around a local community hub or a fire, is a good time to talk about things. I remember once, many years ago, I was in Chakradharpur in Jharkhand, and obviously the women came back from work late evening, almost at sundown, did whatever they had to do at home, and late evening is when we sat for a meeting. I was still a novice professional, and I looked at people in the meeting and I thought, oh man, most people are drunk in how we understand drunk in the traditional sense of the word. In tribal cultures, rice, alcohol made out of rice is a staple part of their diet. It's a very important calorific input. Intoxication is a byproduct, and for communities that work very hard, it probably serves a very important purpose. Anyway, and being the novice that I was, I said, okay, let's have this conversation when we are in a better frame of mind. And the women turned around and told me that this is our standard. This is how we are. Want to talk to us like this. So you learn along the way that you adapt and adjust to a community, and you adapt to the cultural norms of the community. Talking about mental health in a marketplace, in a very vibrant, moving marketplace might sound very chaotic to some, but it's probably the best way of getting attention of some of the folks who come there very regularly. And you will see that often people who you may have not even noticed as passerbys later approach you for help. The other point is the cultural belief and the context, especially around religious belief. For many of us across the world, religions and rituals play a very important role as anchors, as support systems, coping mechanisms, and anchors. And it's absolutely true for a rural community, if not more. And does every belief need to be challenged? Is there something positive in certain beliefs? And this, of course, has to be weighed carefully, discussed with professionals, and looked at with nuance. It's not a black and white situation. There are obviously shades of gray all along the way. But let's take a simple example. The idea of possession is very common to many cultures. Is it always bad? Does it always need formal professional treatment? I leave that for you to ponder for a minute. And let me give you an example. So often when there is a need for help, we step in, we help. Programs that are working with rural communities, engage with stakeholders, and I'll talk about that in a minute. But let me give you an example. This was a person who was apparently possessed, who probably had a textbook case of conversion disorder, who had those long hair, etc., and who would sit in these trances, and people from a lot of people from the surrounding villages would come touch the feet of that person, put some money there, etc. As treatment came into play and as the person became better, or so-called, less mentally ill, the jatas went away, and so did the people, and so did the livelihood. So what happened over here? And the family really turned around and said, "Ye kya kar diya tumne?" So wait carefully, look at the consequences. The other thing that using the same example, mental health is not just mental health, right? This is one of the most interdisciplinary sciences and interdisciplinary approaches there is to working in the human space. And if you want impact, you can't go at it alone. You need everyone in it with you. You need to work on people. How can you just talk mental health with people who are struggling for basic livelihood? You have to have some channels of addressing some of those issues, and therefore integrated approaches where you're looking at multidisciplinary modalities. A person who's experiencing domestic violence through day in and day out is definitely not going to be mentally healthy. And no amount of mental illness treatment is going to address that. You have to get to the core of the issue. You have to ensure the safety of the person. How are you and I going to be so-called mentally healthy if we were put in the same situation? Probably not. So these are some of the things that we look at constantly in rural settings. The other big elephant in the room is working with faith healers. And countries like India and other LMICs have a lot of experience in this space, especially in all the other healthcare domains like maternal and child health, etc. And there's been a lot of debate and discussion about who to include, who not to include, who's allowed to give care? Oh, they're not trained enough, etc. When it was working with the DICE, there was this debate in maternal health and child health. So my own personal take on this is, again, an inclusive approach works best. You can give a mental wellness message 1,000,000 times, and probably a community leader, of a person of religious importance to that community. It could be a priest, it could be a pujari, it could be a faith healer, it could be anybody. The message coming from that person probably carries a lot more weight because there is inherent trust that people have with that person. Over the years of working with funding organizations and working with very, very large organizations like the organization in tribal Chhattisgarh, which is a very, very large healthcare provider in that region, and did a lot of community outreach work. When we ran an evaluation of the piece that was being funded, one of the primary findings that came out is that the first point of care remains what we call as rural health practitioners. So including them, working with them has given success, and there are several models that work with them, called the Dawa Dua model, whether it is in rural Madhya Pradesh or whether it is in Gujarat, and engaging and working alongside training faith healers and religious practitioners in recognizing signs of severe mental illness, in giving them the tools and techniques for dealing with distress, works. And there is evidence around this. There is also evidence around the fact that temple therapies work. So looking at evidence, and always looking at evidence and carrying that along and creating new evidence as we are in this space of implementing. And so it is that, each of us as human beings interact with people. And if we have that basic training in eventually what is mental health literacy, it is knowledge, as Dr. Raghavan had pointed out. It is not only just knowledge about mental disorders, it is knowledge about how do you enhance your well-being? What are the self-help tools and techniques that you can use or help your friends and families with? How can you be an informed peer? And so it is that all of these tools really can be used in rural communities. The other, and probably I'm running out of time, but the other thing that it's important to talk about is, how do you take scientifically robust or reliable information to communities in a usable manner? How do you remove the jargon out of the scientific evidence-based stuff? How do you make it more palatable and usable, employing modalities that will reach communities? What is it that communities engage with? And there are different forms of engagement and communication. I remember many, it seems like a different lifetime now, when we were working with current drug users in the depths of Nagaland. We used music and guitar hotspots as a way of engaging with young people, because that's very relevant in that society. Music and guitars, every young kid is attuned to that, and those hotspots became a hub for coming together, not talking about, oh man, are we going to tell them don't use drugs? Everyone in the world has told them that. So what is it that the first point of interaction is engagement. If you've got the engagement, then you can go to the next step. Nothing's going to really work without engagement. So finding those relevant pegs, finding those mechanisms, whether it is a satsang, and lots of programs do this. Lots of programs have traditionally done this with health. The same can be brought into mental health. Can you recreate some of the bhajans to give a message around mental health? Yes, of course, it's being done. And it's being done very well in different parts of the country. So there's a need to bring out this information. There's a need to share good practices that really engage with communities using street plays. And I say this with caution because you can do it badly. So using well-developed street plays. Now, also the one thing, and I am a convert, as a person who has believed in evidence-based methodologies, I have learned over the years the importance of folklore, art, and engagement as a very powerful tool, not just with young people in communities, but also with severely ill people, where language is actually a barrier. Modalities such as this can build engagement pathways that like nothing else can. So there's a whole lot, and be guided by the communities. That's I've said it previously, and I will repeat it, that if you listen, you will know what a community wants. Be guided by it, and tune in the program strategy to that, and there will be steps forward. So may I leave this at this point, Dr. Raghavan, because I can talk till the cows come home.
Thank you very much indeed for that excellent introduction to the theme. And I think you said it all in that brief space of actually listening to the community, tuning into the community, and how is it that you actually spend time with the community. And I think they're all important factors in understanding the community perspective. Because I think from a medical perspective, I think people often think that we have to provide some kind of, there is a problem here, and then we have a ready-made solution here, and then we are actually going to give them this ready-made solution. In many of the contexts, I think that we have actually learned that particular approach does not actually work, because obviously people are not interested in the solution. First of all, they don't know what our solutions are in the first place, and I think many people don't actually follow that perspective. And I think I fully agree with you in terms of how the professional perspective versus the community perspective highlighted very eloquently in this space, and also how beautifully you actually brought together the social context of that illness. You didn't actually say it fully, but I think the social construct, the social model of mental health and mental ill health. And I think why in today's health and healthcare perspectives, it is important that we look at very much from a social model as well, not purely from a medical model alone. And I can give you a number of examples as well as to what you've just highlighted in things, in some of the ways in which we engaged within the Mehelp project in Kerala. When we engaged with the rural communities and tribal communities, we did a play for about 20 minutes, and then the community had an opportunity to actually express their thoughts and feelings and how the community actually identified with that particular issue in their family or somebody whom they actually know, and how the community actually came forward. And there was a kind of a drumming and music, and it was nothing to do with what we were actually doing, but the community was actually partaking in that venture. And I particularly remember this episode in Attapadi. At the end of our interaction with the theater, everybody was actually kind of drumming around and dancing around in that auditorium. Then I really realized that yes, this interactive methodology, this might be one way of actually formulating an intervention in mental health. Because I think so far, people actually often give medicines, etc. Yes, I think, and again, there is a stigma around how you actually approach psychiatrists or psychologists or some other people. So, but I think some of those contexts as well, the primary care perspective, and how they might actually go and see a physician, and whether they are knowledgeable enough in terms of mental health and mental illness is another factor. I think that is very much required in terms of the training perspective as well. But I think knowing about the traditional healers, the faith healers, as you rightly identified, the religious belief systems, the spiritual kind of context about things as well, And what are the cultural norms? We got a rich cultural heritage. How that cultural heritage is actually formulated in terms of how we make meaning, how we make sense of our own illness or disabilities or other things is actually very much important. And I think following any of those religious, spiritual, cultural, or other cultural heritage norms is nothing superstitious. You don't think it is superstitious. It is a way that one leads a life. And I think it is absolute rubbish of current today's medicine question. These things are superstitious. I think it is how a person makes meaning. And I think the problem is today's medicine does not understand as to how they need to actually work with communities and things like a defense mechanism that actually, sorry, it is superstitious. It is not superstitious at all. So I think it's important that we come together in kind of a collective understanding from an individual, family, and a community perspective. So thank you very much for that. I think that's a beautiful introduction and a wealth of your experience in that short space in terms of our discussion around mental health literacy. People who actually want to ask questions, please feel free to raise your questions in the chat box or the question and answer box, and we will try and answer them live. So, from your experience, can I ask you a few kind of points from your experience? How do we get the professionals? Because you've got a wealth of experience of working with a range of professionals in the Indian context. How do we enable the professional crowd to tune in into the community perspective?
Yeah, a very good question, and challenging, yes, of course. And I would say beginning with me, the professional that I am today, I wasn't when I was freshly minted out of university. So I think we need to start there and bring in this community perspective right into our syllabuses and our training and our courses in minting out professionals. Getting in community stakeholders as part of regular training, placing people in community setting. Well, a lot of academic courses do this, and I think the ones that do it get a better quality of better quality of professionals. But going forward, so the first point is that you start right at the training stage and you bring in this thinking that community is an important partner. One of my bosses who's done commendable work with sex workers and the globally famous Shonagachi model, or the DMSC model, Dr. Chana is no longer alive today, but he taught me that, from passive recipients to owners, if you don't take the community along in services, then you will do a project and get out. So that's the thing and there is a journey. There is a journey from being service beneficiaries to being service owners, to have a say in how services are shaped. So professionals who get an opportunity to work in such programs obviously learn it on the job. And there are several training programs that come up. And I think one of the things that so-called expert mental health organizations also try to do is bring out this learning in different ways. So various methodologies are being used, but it is difficult. And I know from my most recent experience of doing the DMHP, the District Mental Health Program in Nagpur, the critical turning point was finding a psychiatrist who was community oriented and community aligned, not a prescription writing psychiatrist. Of course, the program eventually found not just one, but more than one such psychiatrist. And that was the turning point. So there's a journey to go there.
Okay, thank you. So I think anyway, sort of along the same kind of wavelength as well. We talked about culture and how do we sort of try to bring in that cultural knowledge to the professional training perspectives, really, because I think professionals often think that for whatever reason, that culture and cultural heritage and all those things may not be that much relevant. However, as you rightly said, there is a converted group of professionals as well here in terms who actually rightly think that there is cultural knowledge that should be brought into the kind of practice context. But in the UK perspective, in the psychiatry and psychology training in the UK, they actually get 1 day training about different cultural perspectives or different ethnic perspectives. That is in the 4 or 5 years of training, just 1 day, sometimes even a half a day. So there is very little understanding about the cultural narratives and how people think, how people bring in various contexts in it. And in the Indian context, can you sort of share your kind of experiences of how it may have actually happened, or what any examples that you can actually highlight, or whether there are gaps that still need to be filled in relation to how culture could be brought into the kind of training, and not just in the medical profession, but right across health and healthcare professionals?
There is a plethora of examples in healthcare and in mental health that interweave culture effectively with in designing and delivering services. Let me give you a few snippets. Using chudis to monitor maternal health and creating a flag for high-risk pregnancies. So this was used again in a Tata Trust partnership in Purvanchal or Eastern Uttar Pradesh. And right up to the system, the topmost level of the system, everyone knew about this model. So it was a 4-chudi system. It was basically a community system which the community designed and developed. So for the first trimester, it basically used 3 colors of the flag: the green, saffron, and white, with white being in the center. So each trimester was 1 color, and the whole IC and the whole campaign was designed around this. The foods you can eat, the Tikakaran, etc., was all talked about in this language. And if the woman was a high-risk pregnancy, there was a red chudi in the other hand. So the entire system recognized that here's a woman who needs immediate care, and she needs to be, you avoided 3 delays that really lie at the root of maternal deaths. And you took the person right up to the top where there was blood storage available, and where there was an anesthetist and a gynecologist. Now, this is just giving you one little example of how culture can be interwoven. Celebrating festivals, interweaving well-being messages in it is done by several pieces of work across the country. Looking at rituals as mechanisms that promote well-being and build resilience, and like you rightly said, that you can call it defense mechanisms, but are they really that? They are essentially a community coping mechanism. Your belief in karma, your belief that like I remember when I was a child, and if I lost something, my mom would say, maybe it's the universe's way of equalizing something that you may have taken away from someone else. It may sound very trivial, but it gave me comfort, and it told me that it wasn't such a major loss that I had suffered. It was just a balancing act of the universe. So these are coping mechanisms of people, and they need to be respected. Why do we work with, so why do we not leave them alone? Why do we not say that, oh yeah, okay, you got your coping mechanisms, go, right, do your thing? Obviously, there is a need for mental health care, but that need is based on engagement. There is no right versus wrong. There is a need for partnership. And going at it from the cultural heritage, from a cultural context, actually helps you make better inroads, not just better inroads, but helps you harness that wisdom that is already there, and different modalities can be used. For example, we used to use Ganesh Utsav mandals as a very important modality of talking of HIV transmission, and unfortunately, most of the roots of bloodborne disease transmission was so-called, shunned or looked very stigmatized by society. We placed them right next to the idol, and gave it that place that people with HIV need to be looked at in a more humane manner. And there were people who were running such mandals who were very open to such conversations and such dialogues. And I hope Ajay Bhai is there in the audience, and I hope he will pose a question. But he used to be the mayor of the Vasai region when I was working there many years ago. And we used to use Holi as a modality of engaging with the community. And it was considered a very important occasion, and the Holi was lit by the mayor. And the whole idea was turned around. So we burnt the effigy of the virus. And the whole idea was fight the virus, not the person. So similarly, mental health has also used different modalities, situating programs within temple sites or within healing sites, as was done in Chhindwara, as was done in Gujarat, or is being done in Gujarat, where your primary message givers are the Maulvis or the priests running those sites. And if you look at cultural heritage, there is this place in Galyakot, which is Bhilwara district in Rajasthan, where there is a very important Bohra shrine. It's a very big shrine. And the Bhils, it may be a Dawoodi Bohra shrine, but the Bhils think of it as a very important place of worship for them. And there's a whole huge area that is kept just for people who, if you looked at it from a lay perspective, are doing vague and weird things. If you look at it from a professional viewpoint, it's almost like a daycare center for psychosis. And that's also the case with Nizamuddin, the Nizamuddin Aulia shrine. Many people who come and sit there day in and day out suffer from very debilitating illnesses, and this is a safe space for them. They come in the hope of health and healing, and we can use these modalities primarily through engagement, not by stepping on people's toes.
Thank you very much for that. I think that's very valuable, very sharp way of actually looking at some of how culture and cultural integration need to take place in the kind of professional context, and also into the daily practices that can actually absorb the religious festivals and the context in terms of how we promote health and well-being. So thank you for that. We have a question from the audience, Sakshi Sharma. So the question is how to encourage people or patients to continue with the treatment. And people or patients start with treatment, but they don't complete that, and how they don't actually adhere to the treatment mechanisms. What can be a community-based approach in this context?
Thank you, Sakshi, and I'm sure Dr. Raghavan will add to my few points, but that's a brilliant question. So it's the bane of psychiatry, right? First is getting people into treatment, and then having people continue to follow up. But what I'm going to share is just my learnings, and of course there's a whole lot of evidence around some of these things. But so what is the person who's coming to you seeking help really wanting out of that? And we know now, there's enough evidence to tell us that one of the most important tools for adherence is constant engagement with the person. You can call it technically as psychoeducation, and there's a whole lot of science to psychoeducation. There are a whole lot of stages and steps to psychoeducation. But in a nutshell, what does it really mean? It means constantly engaging with the person, listening to the person. What is that person telling you? And what is that need coming out? You can call it a needs-based approach. is this treatment meeting the expressed need of the person? Often all of us professionals make these mistakes. Who is our primary focus in discussions? Is it the family, or is it so-called the index person or the identified person? How much time are we giving? Some of the stuff that the person is telling us may not sound relevant, but engaging with the person is very important. And I can tell you from experience that, when we were working in the Nagpur Mental Hospital and our case managers, there would be hours of no communication. There would be hours of no engagement, because of course the person is going through a very traumatic phase, and suddenly there would be eye contact. And I remember my case managers coming back so happy, and ma'am, aaj usne meri taraf अच्छे से देखा. It was, but those signs only come when there is engagement. So there's a whole lot of tools and methodologies for enhancing adherence, but the bottom of it is engagement. And how do you get a community to see, mental health and well-being cannot be just the state's responsibility or the responsibility of the professionals who are working in it. Like I said in the beginning, it's our issue. It's at our doorstep today. It is each one's issue. And it is a collective responsibility of the community to take care of its own well-being. So I'll let Dr. Raghavan add his views to this as well.
Yeah, thank you very much. And I think, yes, you rightly said there is a community responsibility. There is also the individual and family responsibility as well, in terms of how the treatment is actually continued, or whatever solution is actually offered as well, how they actually take that up on and how they continue with that practice. Let me also give you one example that we actually experienced in one of the tribal areas where we worked, is that we're after the, once we actually had the theater, a kind of performance and engagement with the community. The next day, a lot of people who have had problems and who never actually went to see the local physician, they all started going to see the local physician. So we didn't actually do anything. Just a kind of theater experience and interaction actually helped them to actually go and seek help by themselves, not out of compulsion. And I think that still continues. We thought that was actually intervention ready-made. So we could not even, that was actually the real beauty of it all. And I think so we could see that, how this little kind of stuff, there was very lateral way of thinking, how we did the play and how the people actually engaged with us. People understood it. People could actually identify with it. And people knew what the solutions were. One of the solutions was actually, I must also see somebody else who might be able to actually provide some other kind of help for me, rather than our traditional practices, etc. So that's what the kind of health humanities as a discipline comes into force, in terms of how we can enable individuals, families, and communities to actually have a look at a broader sense, in the holistic and collective way of thinking, solutions to mental health issues, and also to creating mental health and well-being as well. I think, Tasneem, you mentioned about resilience as well in the previous thing, and resilience is the key. And I think how people construct resilience. And I think it's easy for us professionals to actually label somebody actually having anxiety disorder, bipolar disorder, depression. That is a simple exercise. But I think, how do we measure people's resilience? How do we enable people to become resilient? How do we enable people to tell the stories of resilience? And if we collectively enable communities to tell stories of resilience, that in itself is actually a major vehicle, major pathway to create that mental health and well-being in the communities. So rather than, I think it may be a radical way of actually looking at public health, but rather than actually having alongside the primary care centers, we must also have storytelling centers alongside the primary care centers as well, which might actually have a different story of how we might actually progress. So, it is one of those things, and I think it's important. I think it's important that we look at from the public health angle, from the public mental health angle, how we try and look at different ways of actually doing things. We have another question from an anonymous attendee. There are a few research that tries to justify cultural practices by trying to bring it under science. For example, instead of viewing karma as a coping mechanism, they try to present it as a universal law. This is not a good example, but I think there are similar trends. How can we as professionals be better at making this distinction? It's a difficult question. Might have a different tangent to it as well. But anyway, we will have a go.
We'll have a go at this. And yeah. So, okay, the first thing that I would say in response to this, first and foremost, thank you for the question. All views and all opinions are obviously very welcome, and that's the whole spirit of inclusion. So here's my view on this. Like I said, there are things that I learned and picked up along the way, but at the core remains my training of going by evidence-based practice and doing no harm. So unfortunately, the most investment, or rather, I won't even say use the word unfortunately, up to now, the most investment has gone into pure science, molecule development, those kind of things, pharmacological interventions. It is for us professionals to bring that kind of robustness and design to, so to speak, messy interventions. It's not a pill. Engaging with the community or using, looking at cultural coping mechanisms is not a straightforward pill that you can do in a randomized controlled trial. These are messy designs, and yet they are possible. And I know for sure that there's now a growing body of evidence, and with organizations or entities, entities of academic rigor, such as the IITs, coming into this zone, looking at some of the traditional wisdom that religion brings or culture brings into the play. So hopefully we will have more robust evidence, but it is also for us to, and I think the body of implementation science is also very important, and we need to create evidence as we go, looking at what has worked, what has not worked objectively, and bringing that out into the public domain for others to see and evaluate. Yeah. So over to you, Dr. Raghavan.
Yeah, thank you. Thank you very much. So I think, I will take the point that, yes, science is advanced, but science has got many limits. And I think science does not actually answer everything at all in life. There are many unanswered questions in science. And that's where some of the kind of other practice might actually come in, and how that might be actually able to actually absorb and address things in a very scientific way as well. Some of the traditional things. And who says that culture is not actually science? It's only the scientists who actually say that culture is not actually science. The cultural professionals don't actually think that that is not science at all. They think everything is actually all encompassing, all cultural, all inclusive, etc. So I think having a broader idea, having an inclusive way of actually looking at things actually helps at things. I know, Tasneem, there are many places in India that actually have a traditional healer referring people to psychiatrists, and psychiatrists actually referring people to traditional healers. There are many accounts of that in Delhi, Calcutta, and many anthropologists have actually very carefully documented that process over the years. So I think there is that mutual working practices actually happening.
Yeah.
So
I agree. Yes, Dr. Raghavan.
Sorry, go on. Sorry.
No, yeah. So I agree completely with you, and it's and as you rightly pointed out, this is a growing body of evidence. We obviously don't have the answers to everything in the world, and hopefully, each piece of this, as we pick up and look at it, delve deeper, each piece is going to lead us on and give us better insights.
Yes, that's exactly true. And I think, say, for example, we have successfully kind of defined what autism is, say, for example, to give you an example. But the kind of approaches that we need to take for young people with autism or adults with autism comes from a diverse range of things, not just from medicine alone, because medicine doesn't actually have many of the answers there. So I think how we try and bring a range of other methodologies to actually provide solutions, provide help for the person and also for the families, encouraging communication aspects, etc. All those things from different disciplines, really, not just from the medical field alone. So I think it's important. And I think the West is actually slowly realizing that that there are limits to medicine, and that we need to actually try and include the humanities people here, and that's why a lot of the recent, from the UK research councils, they have a lot of grant calls, which actually calls for interdisciplinary practices, which actually looks at health humanities as a way of actually addressing things. And say, for example, recently the Arts and Humanities Research Council in the UK is actually trying to actually help the health disparities in the UK, trying to see why is it that certain communities don't actually access services? How can we actually address the kind of health inequalities rather than purely from a medical angle? We're looking from a health and humanities angle. So things are actually looking from a different side around the world. I think in India has a good track record of those things for a number of years, and I think we should celebrate it in many ways. We should provide them as evidence things. There should be more research in relation to how it might be beneficial for some of those things, rather than thinking that this is actually totally unscientific. I would like to know what is unscientific in this day and age, because when evidence actually changes from day to day, then evidence only matters when somebody else's paper actually matters most. So evidence is not very much reliable in some respects because there are individual variations of that evidence. So I think it's important that we should actually try and look at evidence in a different style as to what the person's own perspective is. Here, we are actually talking about a lived experience of the person. Here, we're talking about lived experiences of a family or a community. And I think that is the real knowledge. A psychiatrist or a psychologist only practices what they know in terms of what they've been taught. And a person with mental distress knows best how he or she has actually been through that process, the kind of pathways they have actually taken to actually kind of try and resolve some of those issues. So who is a better professional, the psychiatrist or the patient? I question that.
Yeah, and look, a lot of healing approaches or a lot of approaches have actually harnessed that, no? A case in point being the anonymous groups, the Alcoholics Anonymous or any of the anonymous groups. It's a peer-to-peer learning modality. Look, I've done it this way, and here's a way, and that might help you. So there's enough work on such approaches to tell you that the lived experience, the wisdom that rests with people has value.
Yes, I think it's so. I think the spirituality, because there are well over 200 papers when I looked at it about a few years ago about how spirituality actually helps to overcome some of the health conditions, not just mental health, but many of the health conditions. And most of those papers actually have come from states and not from somewhere else. So I think in a way, how spirituality influences one's belief systems, and it doesn't necessarily. I'm not talking about religion here, or the ways that one might actually create that wellness. There are different ways, and in India has a good tradition of yoga and meditation. They are not religious in the context. And I think, and how that might actually help somebody, people to develop that well-being. The well-being is actually the most important thing, and I think it is time that we actually moved away from the reductionist model of the health kind of context. When we look at everything is actually very symptomatic, very reductionist way. Psychiatry is very, very reductionist way of looking. I think it's important that we look at medicine from a strength-based perspective, because people have capacities, families have capacities, and I think how we can bring in that capacity for that recovery mode. That is most crucial, and that is an intelligence of the profession to work with the individuals and communities to put them on the track of recovery from their own capacity building perspective. I think that is quite crucial.
Yeah, and look, people who work with severe mental illness, like I have for the last 7 years, where I worked inside a mental hospital, this was proven every single day that, so-called people languishing who are considered long stay in psychiatric hospitals, and where there is no clear pathway to living in the community, on your own steam, so to speak. And you find that it's just a matter of engaging, listening to the person, working alongside the person, working with the potential that the person already has, and that is always there. No, that potential is always there. So I really echo your thoughts on this, Dr. Raghavan.
Yeah, yeah. Are there any other questions that feel free to actually raise any other questions while we actually getting we get carried away with these discussions. So I think feel free to actually raise those questions. Really, I think you mentioned about possessions as a key thing, and I think how do within, I know you mentioned, you sort of explained the process for that, and you explained how that actually plays a major role in terms of understanding the community kind of context, etc. Really, but how does what role do we have the kind of the training of the professionals? Are these kind of contexts actually brought into the training of primary care professionals or mental health professionals? So that they actually understand the meaning and the relevance and the customs and the norms around that?
So I'll tell you what has been done. Okay, and I'm not sure that that's the only way. There could be other modalities as well. You work with professionals who are already in the space, and you help professionals look at how culture shapes their own day-to-day life, and how that has a central role in decision making, in how they operate as human beings. Like one of the first exercises, and I'm sure, Dr. Raghavan, you've used this millions of times, we use in training on adherence management, is ask the group of professionals how many times is it, most of us come across a course of antibiotic ever so often in our own lives. How many times is it that we have completed that course? And what are the reasons for why we have not completed that course? No? And these are such, so the modality of training on learning to work participatorily are basically participatory approaches to training. And I'm happy for anyone in the audience as well to chime in on this. And Dr. Raghavan, please add your experience to the mix as well.
Of the comments from the audience in relation to that, so I think feel free to actually say your views. If you can raise your views as to how that might actually happen. So how do we? I think it's I think what from thinking from the futuristic way of things, of how mental health services need to be organizing in many countries. I think it is time that we actually think more of a collective way of actually looking at things, the kind of examples that we have already stated, really bringing in different ways of actually practices, alternative practices, spiritual practices, along with psychology and psychiatry, and might actually give us a better understanding of things, really. Because I think recently I have a PhD student actually with me looking at how much of this cultural business is actually being used in psychiatric interviews. And many psychiatrists actually don't understand religion, so they don't actually ask anything about religion. And I think in places like where I live in Leicester, where there's a very large South Asian diaspora. And I think we're quite religious, and I think it's important how we bring that religious context into those psychiatric interviews as well. And so professionals who have very little awareness of religion or spirituality, how are they actually going to be exploring that perspective with the person in question? It's important.
So we are raising a very, very valuable point, and we've seen this in in a million different contexts in healthcare. Yeah. So, for example, when vulnerable communities go to seek help, the way they are treated or addressed by the service providers determine health seeking behaviors completely, right? I'll give you a simple example of conservancy workers. They obviously don't work in the neatest of situations, and so probably when they go in for health services, they're probably smelling different or looking different, and the way they are treated determines how they think of accessing services, that it's the last port of call, if ever, for them, because they know that they are not welcome there. And I'm giving you an extreme example just to illustrate that point. But I remember when we started working with one of the Nizamuddin Basti programs. Nizamuddin Basti is what, 2 kilometers away from two of the largest hospitals in Delhi, AIMS on one side and Safdarjung on the other. But this is a certain community. It is a marginalized community. 39% of deliveries were home deliveries. And if Jyotsna is in the audience, you can actually say if I've got the number wrong. But this is something that's stuck in my memory. Why would this happen in urban Delhi? Because service providers have a different way of addressing, and people from this community did not think that they were welcome to seek services. So, and then we turn around and say that communities don't seek services because we are not in tune with them. So, and as healthcare, in fact, the most, and this is something that has been debated heavily, and I know that there are training programs, for example, for training doctors in bedside manners or in communication, right? And who makes good doctors? Really, people who listen to their patients. I remember my general practitioner when I was a child. Unfortunately, in India, that is a dying out entity, But we used to live in this little town called Vasai, a little away from Bombay. And the most important person in our family was our physician, our general physician. I don't know if he'll even remember me now, but my mom would go and tell him every single thing that happened in our home, and he was counselor, come everything all rolled into one. Why? Because he listened. So
yeah, that's true. Thank you for that example. And I think it's important that how we look at it from a broader, very inclusive cultural perspective. So I think in terms of looking at some of the, can we just go back to one of the basic questions in terms of, from your experience, about the kind of prevalence of mental ill health, from you traveled up and down the country, and worked with various agencies, etc., in the Indian context. How do you kind of see the kind of prevalence of mental ill health in rural communities in India?
So I'll respond to that in a couple of ways. The first is, the level of distress and how it expresses itself. Many years ago, we were actually literally in the middle of the monsoon, walking the villages of Vidarbha. This was preparing for an intervention, basically addressing agrarian distress, and there was a whole bunch of psychiatrists with me, including people like Vikram, Dr. Vikram Patel, etc. And we were really walking the villages and talking to people and understanding their perspective and the amount of distress that we came across, and the manifestation of distress that didn't say, "Mujhe bura lag raha hai." No, that wasn't, but the many forms that distress took, the endless amount of chronic pain that it manifested into, etc. And this was, of course, an area that was really suffering, and people might say inordinately so, but maybe rural realities are like that, where opportunities are very varied and different. And look at the young people today. Again, this was a conversation with one of our partnerships in Uttarakhand that I had several years ago, and unfortunately I have a memory where this sticks in my mind. And I remember discussing this with him, and he said, today's youth is actually even more confused than we were, because on the one hand, there is a slight increase in education, etc. It's not so increased that opens up doors and opportunities, especially in rural India. But on the other hand, it makes traditional occupations not acceptable to them. The level of aspiration has changed, and that brings in a whole different level of I don't want to label this as anxiety or anything. It's just a different level of experience and distress that those communities are experiencing, and it's their reality. And we need to look at distress in this context. And coming back to the actual question of prevalence, so and this is the first part that I have said is anecdotal based on my experiences. Now we measured this. We measured this in the district mental health program of Nagpur, which does household-based screening. And on the data set that I last looked at, there was, we used an instrument called the Kessler 10, which is really a distress instrument. It's not a disorder scale, it's a distress scale. And its international cutoff is 20, and we took a cutoff that was different, looking at LMIC settings and volumes. And there was at least 30% of people reporting a score of 30 and higher. Okay, so and at least 8% of that was populations that we needed to look at in terms of existing serious or very debilitating conditions. So, the volumes are really high, and these are for people who have come and been part of the screening. Lots of people out there, and the more distressed you are, the lesser you want to go out and talk about it. That's the paradoxical nature of distress. So, so I think we're sitting on much higher prevalences than what our data points are really telling us.
Yes, that's true, and I think obviously the kind of in the because I think I'm glad that you carefully used the word distress rather than the disorder kind of context, because distress, many people actually express distress, but it may not all be kind of diagnosable illness modalities really, and I think it's understanding that from a professional perspective is quite crucial. Because I think recently the DSM-5 is sort of looking at grief in a container, the kind of that as another symptomatology, another kind of formula for that. So I think perhaps by the in our lifetime there might be all our emotions coming part of different aspects of DSM 11 or ICD and DSM-5 or ICD-11 or whatever that is really. So you'll be walking like robots in relation to the specific solution for a specific.
Yeah. It's pathologizing normal human experience, So if you don't experience, like I tell a lot of people whom I work with directly in terms of services, or even when I was directly training teams, if you don't experience grief at loss, then probably something is not all right. Because it's a very natural expression of emotion, and it's simply human to do that.
Yeah.
Now we allow, and look, there are so many cultural traditions that allowed for people to. Do you know the tradition of the Rudalis in Rajasthan? So these are women from the tribal and the local communities of Rajasthan, who would come when there was a loss or a death or something in the family, and they would go through a whole set of rituals and help people cry, and it's a beautiful tradition.
Yeah. True, very true. And I think the social media, I know that the rural community, but I think social media, especially within the urban settings, I think the social media is partly responsible for pathologizing some of those things as well. I think in terms of comparisons between what we see on the screen is not real life. And I think many young people actually feel that that is real life. And I think I know a number of studies over the last few years have actually shown that regardless of the number of contacts and friends that you have on your social media pages, young people are still lonely, very lonely indeed. And I think engaging in self-injury and many other kind of contexts because of that. And I think so. I think that there are again, and I think I'm not going into the realm of critiquing it, but this is actually what is actually happening. So there are, I think one need to be using it responsibly and understandably and knowledgeably. It would be the right way of doing it.
Absolutely. I so agree with you that unfortunately, this is a generation whose primary relationships are formed on social media. Yeah,
Yes, that's true. That's very true. And here we have husbands and wives talking over social media, not face to face. So obviously, that is taking it to the next level of how one should interact digitally rather than face to face. Really. Anyway, so I think it's interesting. We've been here for nearly an hour and a half talking about various perspectives. So it has been and I think it's so illuminating, isn't it, in terms of having this conversation and how we try and bring in different perspectives. And I think the sheer beauty of it, the sheer way in which how we encourage that kind of thought flow and the knowledge and how we bring in that lived experience and personal perspectives and professional perspectives, and bringing that a kind of an additional layer, a rich layer of learning for us all in terms of how we shape our professions, how we shape our attitudes, and how we engage with people, and how we enable and empower people to engage. If that's the basic question here. How we enable and engage, empower and engage with the profession, with the community is crucial. So, any final thoughts from you, Dr. Tasneem?
So this is obviously a very intense and a deep topic, and there's a lot of wisdom. And I would urge the audience who's interested in this to go out, not just read, also go look at some of the good practices that are out there and the content that's available around this. Seek trainings that help you as professionals grow if you are one. And also place the centrality, on, see, it's more and more coming up that service users and caregivers are taking center stage in mental health dialogue and discussion. We just need to practice it in spirit, not just the letter. And the letter is the starting point, and I think we will get there because there is the intent to do that. So on that note, thank you so much, Dr. Raghavan, for having me here.
Thank you very much indeed. And I think that brings us another layer of actually maybe for exploring. And I think how, because services are often developed from top-down perspective. And I think we come to a stage by users and carers need to be shaping up those services what they want, really. And I think it should be grassroots upwards rather than top to bottom way of actually looking at things. So anyway, thank you for taking the time, and thank you for being part of our conversations around Mehelp India Foundation. And it's been very great to be able to talk to you over the last few years and the last year in relation to mental health literacy. And it's a pleasure to always connect with you and also to learn from you, and also kind of all the examples that you bring in illuminates our mind in relation to different ways of actually thinking about it. So thank you very much indeed. And thank you all the participants who have actually been part of this discussion. I know, feel free to actually connect with us. Obviously, this will be on our YouTube, Mehelp YouTube site, or Mehelp Facebook page, and also on our website. So do join us, do help us. Together, we can actually move things. Together, we can create a better conversation around mental health and well-being. Together, we can actually sort of eradicate that stigma around these conversations around health and illness mode. And I think it's important that we make that move. If we don't make that move, who else will, is the question. And I think we should be bold enough and strong enough to actually do that. And I do believe that is when we make life worth living. And on that note, I thank my colleague Parvati for hosting this webinar. And thank you, Dr. Tasneem Raja, for coming along and having this wonderful and imaginative discussions that we've had this afternoon. And thank you, all the participants, for being on board and for all the questions. And feel free to connect with us again. Obviously, there are different mediums through social media, email, and everything else to connect with us. So do feel to connect with us. And thank you, and have a very good evening. And hopefully we will see you soon.
Thank you so much.
Thank you.
Bye-bye.
Bye-bye.